Fortunate enough that I've talked about different ways by which they can start a robotic minimally invasive program, and also how to be able to, you can say, collaborate with your cardiology colleagues. So I'm just going to talk about how to kind of build your hybrid program, how to grow it, and how to maintain it. These are my disclosures. So what's an ideal revascularization procedure? Well, it's delivered in the least invasive manner, as long-lasting as possible. You want minimal postoperative side effects, and complication is reproducible. Least amount of anesthesia, and minimum length of stay in hospital. This type of procedure is what we're all looking for, is the holy grail procedure. So to have a hybrid program and to be able, as you've been alluded by Dr. Balke, you need a committed team, a team that's committed and dedicated. So you need buy-ins from all those, you can say, top notches of the families, of the Godfather approach that it was. The similar thing applies. You need buy-ins from all the stakeholders. And you basically, for example, the way we did it is very critical for individual members, and specifically your hospital administrator, to understand that minimal invasive or robotic ITA harvesting is as good as open, and minimal invasive robotic anastomosis is as good as doing it open. Because the Achilles heel of doing a hybrid procedures, you have to be good in doing minimal invasive revascularization, specifically minimal invasive LITA to LAD. So you need collaboration, coordination from all these different disciplines of medicine to be able to proceed in having a, you can say, successful hybrid program. So what is recommended again is to have a dedicated small group of anesthesiologists, operating room nurses, and perfusionists that you work with on a regular basis to keep their exposure as much as possible to optimize their experience until the volume, of course, increases, and make sure that you're not diluting their experiences. So minimal invasive or robotic coronary bypass is a basically reproducible procedure, and they need to understand that, and you need to support that, as I mentioned, with angiography. So anesthesia needs to be supportive of that, with definitely all the different, you can say, important things to bring to the table, such as making sure that they provide good single lung ventilation, making sure for off-pump surgery, patient remains normothermic. So these are critical things to make sure that the patient is able to properly looked after. Of course, the cardiologists are the ones, or the gatekeepers, have to also buy into this and make sure that they're happy with what they've seen with the LITA patency in LITA to LAD done minimally invasively, and be able to basically be supportive in terms of being able to do a hybrid where they will basically give the LITA to LADs to the surgeon and take care of the non-LAD vessels. And of course, your administration has to be very supportive of it, making sure this is beneficial for the institution, and of course, better patient care. So the way it's recommended is, after you have basically perfected and shown that minimal invasive LITA to LAD, whether it's done with or without robotic assistance, is as good as open, then you can start doing what we say two-stage hybrid procedures. Well, when you do the LITA to LAD, next day or the following day, whatever way you basically think is best for your institution, to proceed in doing the non-LAD vessel PCIs. Once that's demonstrated that's successful, you can have further discussion with the team, with collaborative kind of, you can say, techniques, move on to providing some protocols with your cardiology and anesthesia colleagues to move on to the next level, which would be a one-stage type of procedure. To do that, of course, you have to be able to acquire a hybrid operating room, which again goes on trying to see whether can you use your hybrid operative budget. Do you have to do it through grants? Do you have to do it through a donation? We did it through a Canadian Foundation for Innovation grant. We had the very first hybrid theater in North America back in 2003. And now, this hybrid theater specifically is getting extremely old, is outdated, so through donation, we have to renovate it. So it's critical for you to be able to have a hybrid operating theater to do a one-stage collaborative approach. So then once you have a hybrid room, you start, that's where the integration occurs, is where the arena where you start working together. You do step-by-step utilization of that hybrid room. For example, the way we started to do robotic-assisted cabbages with immediate LITA check, immediately in the operating room. And if the patient needed the PCI, we didn't start doing a DAWI because we wanted the cardiologist to become comfortable with the hybrid OR. we let the cardiologist first do the diagnostic angiography, and we started partaking in that. I actually scrub in with the cardiologist and actually provide some of my basic techniques, and I'm significantly learned a lot of techniques from them, especially wire skills. So you allow them to do diagnostic angiography and then do PCIs, just like a sole PCI, without combined with, you can say, minimal invasive LITA to LAD. Once the hybrid room becomes comfortable with the cardiology team, including the cath lab nurses, then you can move on to the next step where you can basically do a combined hybrid approaches. And it's critical for the operating room team to integrate with the cath lab team, again, as a nursing and anesthesia type, because that was not what the cath lab team is used to. So you have further optimization now, of course, of antiplatelet and anticoagulation regimen. This is where, specifically, if you're doing a combined approach, you need to have team discussions with your cardiologist, anesthesiologist, cardiac surgeon, specifically clinical perfusion, because if something goes wrong and you're using dual antiplatelet therapy, or you're using other agents such as like the direct thrombin inhibitors, which we use, clinical perfusion needs to be fully aware of it, needs to understand what they need to do in case an emergency situation occurs and you have to utilize kind of cardiopulmonary bypass machine. So further, again, development of the hybrid depends on proper patient selection, and that can be done as a team approach. And of course, the results have to be extremely well analyzed, and specifically in terms of the patency rate, both of the stent and both of the LITA graft. And then here, when you can introduce further type of, you can say, advancement, which is called fast-track therapy. Fast-track therapy is these patients can, just like undergoing a PCI, your cardiology colleague needs to understand if they're embarking something like that, they should try to do their best to discharge the patient basically the same amount that they were having just a PCI. So therefore, try to become strategies where the patient can get extubated in the operating room. Specifically in our institution, we transfer them recovery, they get recovered in the recovery room, and then they go to the ward, and this really significantly reduces the length of stay in the hospital, specifically down to 2 to 3 days. So you continue to have regular, again, discussions in terms of the progress, how things are going, specifically talking about the learning curve. Is the procedure length getting shorter? Because, again, it's very critical to try to go to the same type of, you can say, landmark or benchmark that the cardiologists have when it comes to PCI. Improvement in the length of procedure specifically, and of course, you have to make sure that your outcomes are transparent to all team members. So in terms of basically patient selections, it's most important to choose the right patient specifically when you're starting. And you have image guidance as a way to basically making sure that you basically have chosen the right patient. And you have to be comfortable to do the same procedure conventionally or hybrid, whether basically or not the patient, depending on whatever anatomy the patient had. Of course, in terms of patient selection, you should start with lower risk patients and tackle the more complex ones as your learning curve improves. In terms of strategy for further growth is very critical to keep your referring physicians and referring hospitals also involved with what has happened with the type of care you're delivering. So you need to have regular rounds, regular follow-ups with the hospitals, with the physicians, make them to be well aware of the technology, the advantages that this technology could bring specifically for patient outcome, and this will translate to increased referrals because both the physicians and the referral hospitals will understand that this reduces the length of stay in the hospital and potentially can improve patient care. So specifically, you also need to make sure that the patients are aware of this. Patients of today are educated consumers. They go and they search what type of treatment they need. So they demand the best and the least invasive procedures. And to get the attention of these patients, it's very critical to have very well constructed websites to demonstrate the benefits of this combined technology. So you need to have continual team engagement. You need to have quality assurance rounds within the hospital to continue the commitment from the team. Again, the team is anesthesia, cardiology, nursing and operating room assistants, perfusionists, critical care physicians, specifically also administrators. For example, in terms of the economic advantage, if you look at the length of stay, patient stay in the hospital, generally in our institution for hybrids, the ICU length of stay was getting shorter and shorter, so we decided to say, okay, these patients can avoid going to the ICU to basically ultra fast track them and they can be discharged quite sooner. We did a cost analysis that was $5,000 saving per case, which was very extremely attractive to the hospital administrators. So in conclusion, these technological innovation that has been already discussed with my previous speakers is the insular pathway to new combined therapy. The heart team that seizes the challenges becomes the captain of innovation and is able to basically utilize this technology. However, the major risk that we are confronted in today is the cost that's associated deploying this new combined technology for our patients. As I mentioned, patients of today demand improved operation and they prefer no operation at all. And technologies makes the heart team understand what can and must be done by basically co-opting the innovating devices and the new methods that have become available. So therefore, my recommendation is only do a hybrid procedure when you know it's indicated. Don't force it to the patient. Develop and follow protocols. Collect data meticulously and analyze it periodically, specifically as a self-evaluation. This is my team. I'm very proud of my surgical innovation, surgical revascularization team that work closely together. Thank you very much for your attention.
Thank you very much. Any comments or questions?
Bob, that was a great talk. Thank you. There is stent thrombosis rates are extremely low today with long stents. There is a theoretical concern that the hypercoagulable state induced by surgery might increase stent thrombosis rates slightly, and even slightly wouldn't be good enough. What are your thoughts on immediate versus staged PCI 6 weeks down the line?
That's a very, very quick question. We have not looked at that aspect of the hypercoagulable state that get it for the first 24 hours. So in our institution, if we do a staged procedures, my patients immediately after leaving the operating room, when they get to the ward, they immediately go on the dual antiplatelet therapy. They immediately get loaded on another antiplatelet agent in addition to aspirin. So, I mean, of course, if institutions decide to go a two-stage, that's something that they need to look at, because you're right, absolutely, and specifically with studies that basically have shown that has come with Dr. Taggart that you routinely utilizes dual antiplatelet therapy, and he thinks that the reason why on pump is better because being on pump kind of creates this kind of, you can say, platelet dysfunction, so it takes away the hypercoagulable state. So, but that's a very, very good point. So hence, I think if you're doing a two-stage therapy, you should probably use a dual antiplatelet therapy afterwards.
What percentage of LAD doing hybrid versus stent? Because the results of stent has vastly improved. I just looked at the Resolve 3 trial, which is the microcrystals, which is close to the vessel wall. So rather than the stent, a phenomenal 5.6 for 12 months event free in the event interval. So what percentage of the LAD, you understand what I mean? If you have a 1 million stent being done, 900,000 LAD stent.
Correct.
What percentage in your institution you're doing hybrid or Lima to the LAD out of the total LAD lesions you see? Is it growing up? Is it growing flat? Is it a 10% or 1%? Because that's important. At the end of the day, how are we going to get that LAD for our hybrids?
I think based on what I've basically mentioned, I think you have to get your cardiologists acceptable that it's not just at the time, but long term, you get the LITA advantage survival to it. So therefore, I think that if your cardiologists are able to understand, of course, they continue to do their ad hoc stenting, not knowing that, but I think if you, in my institution, basically I would say close to 95% and above, the LITA goes to the LAD if the LAD is solely diseased or if it's a basic anatomy that's suitable for hybrid. That's because of the way we've been doing this since 2004. We started the hybrid in 2004.
If you do, let's say, 900 LAD stents in your institution, would you get 10% of that? Or LAD lesions you see in your institution, 900 LAD?
But also it depends on if the patient is suitable to undergo a surgical intervention, we get probably 100% of it. In our institution, yes. Yes, if the patient is a surgical, non-surgical candidate, is like elderly things that they get stented. But if they're in their basically ages that the lead has been shown to confer advantage, close to 100%, yes.
So most all LAD comes to 100.
Absolutely, because we've been doing it for now 15 years.
maybe let's move on to Randy, man. Great comments, but unfortunately we don't have a lot of time. So
We can discuss more, Dr. Zubair.
Randy Wolf from Houston. Good talk, Bob. The anastomotic distal device was patented in the year 2000. I know because I patented it. The internal mammary, the internal mammary has been taken down thoracoscopically, you know, for 20 years now. So these are good talks, but they're not. It's not new innovation. It's more a system talk, and same with the talk on robotics. It's a talk about how to set up your program, but things really haven't changed that much from 20 years ago as far as innovation. So in your opinion, and anybody else, why is the adoption rate still at 5 or 10% when everything you've been talking about has been around for 20 years?
I mean, the purpose, the path that I took to trying to see how you can make a hybrid program grow is by getting the other team members, specifically the gatekeepers, to understand how it's critical specifically to use the technology that you basically were one of the main pioneers for, that was basically invented 20 years ago, to basically say that this technology is good, so basically let's use it as a team and take advantage of it. As you said, we have not gone any steps ahead because we haven't been able to get the other stakeholders to agree to what is out there, what's available. And that's why we need to work on to basically get them convinced that this technology has been around for a long time, has been shown to be as good as conventional, basically open operation. So let's utilize it to provide better patient care and less invasive care to patients, because technology has improved, specifically in non-LAD territories.
Thank you very much, anyway.
thanks, Bob.
Next and last presenter.